Well, thank you for watching, and it's a pleasure to be here. I'd like to thank Rob for the invitation. We're going to be talking today about arrhythmogenic cardiomyopathy. And what I thought that I do in the next 40 minutes or so is put this a little bit of background for the clinical condition and why it's important to study this disease. Then I'll talk a little bit about the pathophysiology of arrhythmogenic cardiomyopathy, or used to be called ARVC or ARVD from the older people in the room, and the new therapies for ACM that we are interested, we are working. And for that, I will discuss briefly the work that's being done, not by us, by others, about gene therapy in this condition. And then jump to what we've been doing in my group, which is treatment of ACM and the inflammatory aspect of the condition with extracellular vesicles. And then follow with RNA drugs and talk about some new unpublished material that we have on this. So, as we know, ARVC is a familial progressive disease characterized by pancreatic replacement, changes in the electrocardiogram, changes in the MRI and ventricular arrhythmias and sudden cardiac arrest. The patients, they usually are typically when they are born, and they can present in different ways, with syncope, ventricular arrhythmias, heart failure, about 20 to 30 years of age. And often, I say often because it's a quite heterogeneous condition, they can progress and they require the heart transplant no matter what we do. Okay, they present with multiple arrhythmias, VT storms, they get implanted with defibrillators, and they end up progressing with biventricular failure and transplant. And one of the characteristics is in the electrocardiogram, they may have that epsilon wave, that notching on the QRS complex in the right precordial disc, so it's quite characteristic of the disease. So, as I said before, we find that the genetic cause, we can find out about 50 to 70% of the cases. Some of the cases we don't really identify. It's about 1 in 5,000 to 1 in 2,000 population. Depending the different registries, you can see more males and females in European ones, and the US registries seems to indicate that females are also quite affected by this condition. Okay? The pattern is autosomal dominant inheritance, and the normal mutations are extremely rare in this condition. And also, because of the low penetrance, there's a belief that can be multiple hits for these conditions, not only genetics and environmental factors, but many other yet to be identified genetic disruptions that's going to create this condition. So, as I said, this is how a patient can typically present. This is one patient that presented to the ER with a very, very fast ventricular tachycardia that was causing palpitations, a very trained individual. When they currently work the patient, they identified that epsilon wave that was mentioned before, and the changes in the MRI and the genetics confirmed the PKP2 ACM. The patient was implanted in an ICD and received multiple shocks during the years, and subsequently have to go to heart transplant. Very aggressive condition. This is not the typical story. Many other patients, they can present with subtle forms of the disease, and they can tolerate for much more. So, it is a disease of the desmosomes, as you can see in this cartoon, and you have different mutations, being plakophilin the most frequent one. You can also have desmoplakin, desmin, and desmoglein mutations. This is going to affect the intercalated disc and the structure and create a secondary, I would say, inflammatory response that's going to perpetuate the disease. And that, I think, is an important concept, because I think there's that cycle that creates, once we have disruption of the intercalated disc, there's going to be a inflammatory response that's going to lead to fibrosis and remodeling. And even if you fix the genetic defect, that kind of already takes effect. So 50% there are desmosomal mutations, as I highlighted in this slide, and the other 20 to 30% are non-desmosomal mutations. To highlight some of the more frequent ones, PKP2, about 60% of the forms that we diagnose, and You also have other forms, desmoglein and DSP, that are also quite important, and they tend to present with a more inflammatory phenotype compared to PKP2. You do have also non-desmosomal mutations, including ryanodine receptor, the same one that's going to cause CPVT and a leaky SR calcium load and arrhythmias by that mechanism. And you have TGF-beta and other conditions that are linked to that disease. So what I'm trying to say here is that, as you can see, there are multiple linked genes with the conditions that they can affect different signaling pathways. That's why I think the disease is like very heterogeneous, and probably the mechanisms of arrhythmogenesis, they are not single ones, but maybe a combination of many in the different forms of the disease. So the mutations can be linked to the location of the disease. Back in the day, we used to call this condition ARVC. Now we are shifting to ACM because we know that it's a disease that can affect both sides. Some of the mutations, they can affect predominantly the right ventricle, and some of them, they can affect more so the left side of the heart. And we see this clinically. That's why we tend to call arrhythmogenic cardiomyopathy rather than ARVC. The intercalating disc and connections are quite important, and from this group, Shogun and Peters described very nicely how the small isoform of connexin 43 and Chase20 is linked in this condition, and there's decreased expression in patients. And when they were expressed that in mice, they were able to show decreased number in PVCs independently of the structure. So again, reinforcing the issue that the arrhythmia mechanism in this condition is probably multifactorial. Okay. Mutations in PKP2, as I said, there are different ones, but altogether they account over 60% of this condition. And because of that, gene therapy has been developed in an attempt to fix this condition, right? And this is just a small table of some of the studies that they've been approved for humans by the FDA, where they're using AAV gene therapy to overexpress PKP2, the wild type form, and with a hope that that's gonna, stop the disease condition. And we don't have any final, results yet, but these are publicly available reports that about 20 to 40 weeks or 12 months in other studies, they seem to have well-tolerated events, and they did biopsies, and they can show that they increase PKP2 expression. And some of them, they say that in the preliminary few patients that they did, they show reduction in PVCs and improvement in RV function. However, there will be some reports of mild troponin elevation and mild elevation of liver enzymes, which is
So, do you mind if I ask a question?
no, please.
Okay. Yeah. So, because you have this slide, I just thought I might just ask my question real quick. So, the previous slide, we showed all the different genes, so a couple of genes. The question now becomes redundancy. So, if you understand, for example, backfilling, how that works, would that address what happens with patients that show laminate or lamin, for example? Does that make any sense?
Yeah.
Yeah. Okay.
Yeah.
Yeah.
So I think in my mind, it may address to some extent, but not completely.
Okay.
I do not believe that fixing backfilling only is not improve the ultrastructure completely.
Okay.
In my mind.
Okay.
And beyond the genetic defect, I think I'm going to go over that. I think once you have that disruption, there's a inflammatory cascade that kicks in. Okay. That even if you fix the defect, you're going to have to do something about that portion of the disease.
Right.
Yeah. But yeah, I think that's for sure a limitation of the gene that attempts to fix this.
Exactly. Okay. Sure.
Yeah. That's a very good point.
Yeah.
And the disease is a progressive disease, and I'm going to check a cartoon that shows that you have an asymptomatic phase, then they can manifest with ventricular arrhythmias on the way to have more overt heart failure to severe heart failure that the patients may need to transplant, right? And inflammation, as I mentioned before, plays an important role, and there's multiple reports, both in clinical reports about how this can manifest at multiple myocarditis type of syndromes, and also hot phases of the disease where patients do worse. And these, even at the basic science department, there's recent reports about modulation, CCR2 positive macrophages to try to modulate this inflammatory response in these SHIF2 mice to try to slow down the progression of the disease. So we become interested about that because, as I said before, I believe that genetic mutation takes place, then there's the subtraction and a cascade of inflammation with fibrofactory replacement and fibrosis that perpetuate the disease. And that's how we got involved, in this, and very bright postdoc in my laboratory study extracellular vesicles that we know they have, anti-inflammatory and anti-fibrotic potential. And to start, I have to introduce the current cell, the first-derived cell. We've been invented by my institute director many years ago, and they are stromal cells. They are CD105, CD45 negative. They've been studied in multiple clinical trials, and they phase 2 and phase 3 already. And we know now that they are potent anti-fibrotic and anti-inflammatory properties, but we also know that they don't reside or engraft per se. They go away and they have some effect that is not, linked to the cells themselves. And cells are okay. I think, they improve good safety profile, and they also they have issues when it comes to immune memory, immune rejection, and QA and QC, and the production can be complex. So that's why we ask ourselves if we could, use a cell-free product that could mimic the anti-fibrotic and anti-inflammatory properties of the cell. And for that, we start working, like many others, with extracellular vesicle exosomes that they are 30 to 150 nanometer particles that they get secreted with nearly all cell types in the organisms. And they are each loaded with different mirrors and non-coding RNAs. And the payload is very cell-specific, different cells. And even if you get one cell type and you stress the cells in the lab, you're going to have a different content of these extracellular vesicles. The reason why they are used not only for therapeutics, but for diagnostics, especially in the cancer field. And, when we start working with this, we realize that with CDCs, if we inhibit the secretion of exosomes with a compound, we show that the beneficial effects, in this case, in ischemic cardiomyopathy and ejection fraction, was planted. In other words, most, if not all, of the beneficial effects of the cells were driven by the exosomes. Because of that, we embarked ourselves in working with exosome properties in the parent cell. And this is what Yang Nguyen reported, and this is the original paper published, where we use this sheet to mutant mice, one of the forms of ACM, and we use wild type as controls, and we treat them with systemic exosomes in multiple injection doses, as you see here. And at the end of the study protocol, we started at about 4 weeks, and we follow for 4 to 6 subsequent weeks. And at the end, we perform arrhythmia characterization, echocardiogram, and biochemistry and molecular studies. And what we find, and this is just an example of the echocardiogram, we measure the size and function of the RV and the LV, both by B-mode and M-mode echocardiography. And here is the pool data for systemic injection. As you can see here, at baseline, 3 groups, wild type, vehicle, and exosomes were compatible. But at endpoint, we saw a reduction on the ejection fraction on the vehicle treated groups, and there was some improvement with the exosome treated animals. That same trend was seen with the fractional shortening. And when we analyzed right ventricular function with TAXI, we found the same trend. No significant changes at baseline and a trend towards improvement on the treated animals on the far right of the green bar here. So, and this is like related to the biventricular compromise that these animals have. We started very young. We started at 4 weeks. This is the DSG2 mice that we are using here. They're homozygous. It's a quite aggressive phenotype. Most cases of human ACM are heterozygous, and the reason that we use homozygous, most people do, is because the phenotype is much more evident. But I found that if we start the treatment late, when the disease is already very remodeled and fibrosis, probably nothing's going to rescue it. You know, it's something that is important when we're thinking about what will be the situation in the human being, right? And when we study arrhythmias, we perform a standard, provocative testing that we do in our lab. We put a catheter and we do a program stimulation, the same that we do in our patients, to provoke arrhythmias. And you can see here that the wild-type animals were very difficult to induce. That happens. Mice is very difficult to have sustained VT in wild-type mice. When we did the vehicle-treated mice, they have these short runs of VT, a polymorphic VT, sometimes go into ventricular fibrillation. And the extracellular vesicle exosome group, we were able to induce some arrhythmias, but in less amount of animals. And what we did generally were shorter duration. This is the data here about the inducibility, only one wild type versus 8 of the vehicles versus 1 of the treated ones, as you can see here. We also study ambient arrhythmias using telemeters. As you know, provocative testing has a limitation. The positive and negative predictive values are not that great. So that's why ambient arrhythmias are much more important. Especially in ARVC, spontaneous PVCs are important in humans because it's a risk predictor of mortality and it's used as a risk score to decide who's getting an ICD. So that's why we put telemetry, and we showed that animals treated with exosomes have sinus rhythm, and the other ones show salvos of spontaneous VT and increased PVCs.
Sorry, just another question there. I don't know the principles of the model. So were you able to separate atrial dysfunction, arrhythmias, from the VT? Do they occur at the same time, or you don't see atrial dysfunction at all in the context of arrhythmias?
Function versus arrhythmias?
No, I'm talking in context of arrhythmias, sorry, I reconstruct. Arrhythmias, do you see arrhythmias as well as VT in the same animal model?
So the animals in the telemetry, they did not develop AFib, right? Regarding ventricular arrhythmias, the PVC count was increased, right? Okay. And spontaneous non-sustained VT was also increased.
Okay. So,
but we didn't see supraventricular stuff.
Okay.
We haven't seen AFib or AT or SVT. Okay. Most of the stuff that we've seen are ventricular stuff. So non-sustained VTAC, right, and VT. Okay. We haven't captured this animal dies suddenly. Okay. We haven't captured the subset of animals that we have the telemetry. We haven't captured many animals to have that event. Okay. We haven't had any sustained event that was a terminal event so far. Okay. I'm of course trying to get more animals. Okay. When we excise the heart and we perfuse them with a voltage sensitive dye, we did an optical mapping that many of you guys do here, and we were able to see that they have a spontaneous IELs often related to re-entry arrhythmias, and when we did program strips in the lateral heart, we were able also to identify areas of conduction block initiated that re-entry that you can see here on the bottom. We then did isochronal map to study conduction velocity and actual potential duration, and we seen changes in conduction velocity that were partially improved by therapy, and also changes in repolarization, as you can see here, by APD 80 and also by APD 20 and 50 on the bottom. Also, I'm not showing that there. The repolarization was not only affected, but the dispersion was enhanced too. There was much more patchy and heterogeneity in the regularization substrate in the maps that we performed. We study connective 43 lateralization in these animals, and we saw that lateralization was affected when we stay with cadherin compared to wild types and the vehicle-treated ones, the DSG positive ones, and there was a mild improvement with the treatment that we really don't have a good explanation of why it happened. We saw this as a phenotype. We know that the exosomes, they have multiple amino RNAs and non-coding RNAs, but we haven't figured out what's the mechanism of why this is taking place with the therapy. This is some of the images that you can see. You see that both ventricles, the right ventricle and the left ventricle, they show enhanced fibrosis, and this is partially reduced by the therapy, and also apoptosis is affected with more apoptotic cells in the untreated groups compared to the exosome-treated animals. This is just a measurement of the fibrosis, show how the fibrosis is enhanced significantly, and then partial reduction with the therapy in these groups. And this is like some examples of, the wild type and very remote heart treated one with the magnification here as well. We then wanted to try to understand a little bit what inflammatory pathways were linked to this, and we started with tissue sequencing, and you can see here the wild type, yellow and blue, or you can see a big contrast here in the treated animals with DSG, and for sure not complete restoration, but some change going back to the yellowish in some of these genes. We then performed some Western blots, and we found that multiple inflammatory markers that we seen are regulated before by exosomes were affected, and you can see here, some related forms of MSK kappa B, and also interleukins that were modulated by this, include 1 beta and 6. So to kind of summarize this first part that we see with exosomes, we see an ACM, we've seen inflammation driven by different cytokines, and that created cardiomyocyte loss and damage that led to dysfunction and arrhythmias. And when we did the therapy with exosomes, we find improvements in conduction velocity, improved the homogeneity on regularization, and less arrhythmias as a result. Also, connectin 43 was changed, as I said before. We don't have a mechanistic understanding of why that's taking place. So to summarize, I think decreased fibrosis inflammation, reduce inducible and spontaneous arrhythmias, improve conduction velocity and regularization, and improvement in biventricular function with extracellular resistance. So moving on, and this is where we get to the unpublished material, it's the RNA content of these vesicles. In our group, we studied that content from different aspects, and we find that there's a big amount of non-coded beyond microRNAs. There's a big amount of non-coded RNAs that being identified by sequencing the content of these vesicles, right? And we have seen a family of Y non-coding RNAs, one that we named YRX3, that this was published by Alexandra Chu, I'm going to show next. And she described that the target is the macrophages, and it affects efferocytosis and the ability of the macrophages to polarize and digest debris in the intercellular or extracellular space, right? And we tested that in different models. Alexandra Chu, as I said here, tested that in a model of ischemia and showed reperfusion, and we showed that this specific one, YRX3, which is a fragment of pRNA 33044, acted by doing methylation and silencing a kinase named PIC1 that's going to activate MAT3 and enhanced spherocytosis in macrophages, right? And we analyzed a YRF3, this is a sequence here, which is a complementary analog to the human Y4 RNA. And as I said before, she showed that in ischemia perfusion that was cardioprotected by the epigenetic methylation of the enzyme PIC1. We then wanted to test this in arrhythmogenic cardiomyopathy, but we wanted to create a more stable form, someone that can be administered systemically and be more stable over time. And for that, we create a couple of primary and secondary modifications to create more stable synthetic compounds that are more available to be administered systemically. And we did some simple testing, just suggesting, RNAs and trying to see where there was some difference. And we did find that one of the synthetic compounds here, named as TY2, was more resistant to degradation by RNAs, by a PCR. And also when we did functional assays, we thought that the efficacy after RNA was preserved. And we went back to our animal model, as I mentioned before. We are starting to treat the animals here with 4 weeks and follow up to week 10 in this protocol. And we did some wild types. We did beagles, we did TY2, and we did some scramble, which is scramble sequence with the same amount of nucleotides, but in a scramble order. And see if this works. So these are just some examples of the echocardiogram to show some of the images. The frame rate is reduced for the export, so you can tell that this is not the regular frame rate of a mice, but it's for the export of the clips. And you can see a wild type, you can see a reduction of function of the LV and scramble, and a little bit of improvement here in the treatment ones. This is all nice, but this is the data that you can see here, and you can see how the wild type remains with no ejection fraction. Both scramble and beagle tree, they decline over time, and the other one tends to preserve the function over time as 10 weeks. We can see here the different parameters, and this is fractional shortening. Wild type glucose scramble and TY2. The stroke volume by non-invasive echocardiography show improvement here, and no significant changes in the diastolic diameters, and the changes in the ejection fraction are primarily due to changes in the end-systolic volume rather than diastolic volume. So when we study wall thickness, also by echo, we saw here that there was mild changes in the wall thickness, primarily of the septum and taxi that we studied before the specific vesicles, also affected by this RNA drug, like you can see here on the far right. The heart rate was unchanged. In those group, there was no significant change. It was increased in the ACM mice compared to placebo. There was a mild reduction, but not significant. We did, however, see changes in lung weight due to congestion. These animals, they develop bilateral failure, and as such, they do develop lung congestion, and they decrease their ability to exercise acutely. We analyzed fibrosis, both interstitial and perivascular fibrosis by conventional staining, and there was a change in fibrosis in the interstitial fibrosis with improvements in those treated animals comparing to the vehicle-treated ones. Perivascular fibrosis was quite remarkable in all groups without changes in the 3 experimental groups, as you can see here. We then analyzed different genes by qPCR relating to collagen deposition, and you can see some changes here, TGFF and the collagen 301 and TGFF that were affected by the therapy, linking that there's some pathways that have been affected prior to fibrosis. And back to the electrode aspects, which is what I focus mostly on. We found that in surface electrocardiogram there were changes also, and the QRS duration was not affected significantly. There was some remodeling taking place in the disease mice, but there was no changes by therapy. We did see some changes in the QT and the QTC that were significant after therapy in the animals. We also study arrhythmias like we did before with the extracellular vesicles, and this is like the same stimulation protocol that we seen before, putting a catheter and doing prolonged stimulation for VT. And you can see the tracing on the top and in the bottom, and the amount of animals inducible were like 6 controls, and only one treated one was able to induce. And I think this is a way to assess arrhythmias, but I think most importantly, ambient arrhythmias, specifically PVCs, which in arrhythmogenic cardiomyopathy is quite important. And we analyzed ambient telemetry, and we found that no much changes during nighttime, but during daytime, we found that the number of PVCs were affected by this therapy. So that's something that we are interested. We're trying to understand a little bit more about why these changes in the circadian rhythm about this. Optical mapping, again, with the voltage sensitive data, show changes in conduction velocity and repolarization with therapy compared to controls. So you can see here on the far right, conduction velocity and APD-80, as we can see here on the far right. We then wanted to see how these animals were doing. They had limited in the exercise, but the way what it was compared with therapy, it was not affected one way or the other. And the peripheral blood count was not changed with therapy, but it did change from the wild type to the diseased animals. I think the peripheral blood shows increase in white count, and we are in the process of doing flow cytometry to try to understand what is the what's going on with the macrophages in the peripheral blood in these animals, both pre and after therapy. But I don't have any more than the total count to report at this point. Back to the mechanism, as I said before, Alessandro Ciulo described that the ventilation of PIC1 and Smidt led to changes in efferocytosis, and we don't know whether this is going to be the same in this model or not, but we did treated animals, and we did PBMC isolation, and then we performed qPCR in our model after therapy. And by doing so, first we were pleased to see that we found TY1 inside the PBMCs, because the target cell seems to be the macrophages primarily in the PBMCs. We did not find changes by PCR in interleukin-1 beta. We did find some changes in interleukin-6 and some reduction in PIC1, which will go in the same direction. This is what less degree that was found in the previous model, though, so might be some difference that are yet to be identified. And then when we analyze different cytokines in those cells, we also found changes in interleukin-1 alpha and interleukin-6 in the preliminary PCR that we ran in this animals. We confirmed some of the findings by Western blot, and you can see some changes here in interleukin-1 beta and NF-kappa B, and no changes in the population. So to summarize and kind of wrap up what I said about the RNA drugs, I think they improve the function, they decrease fibrosis and this interstitial fibrosis, and they reduce inducibility and the number of spontaneous PVCs that we have seen. The conduction velocity and liberalization were improved, and the mechanism is still to be defined with greater granularity. And back to what I would start the discussion about this cycle of ACM. I think the gene therapy is going to be probably useful to try to express a normal gene, and let Mother Nature decide what's going to happen with the other structures of the intergalactic disk and what's going to happen with the disease progression. But I do think that once this cycle takes place, we're going to need something else to stop this cycle. For that, I think to intervene with something that will modulate that inflammation. And on top of that, I should add maybe to improve arrhythmias, other measures like show with the connective 43 lateralization should be important to treat this condition. I don't think a single target will fix this complex disease. And what are the future directions? Well, I think we need to define the mechanism of ACM a little bit better. We have some signals that PIC1 may be effective, but we need to validate those. We're in the process of doing ultrastructure and EM, to try to understand whether there's some reversal of the structural changes that we know it happens in this condition. We are testing a oral formulation for this to see if it can be applied to, and I think it will be important to check other genetic forms to see if this is unique to DSG. As I said before, DSG tends to be more pro-inflammatory than other forms, so maybe that may be gene specific, maybe not, we don't know. And also do some tox studies long term, in other species as well. So with that, I'm going to stop and take some questions. So this is like a lot of people that work, across the years on this project. I want to highlight Rodrigo, that's been pioneering a lot of the ACM mice work, and Casio, who is been a long-time collaborator of mine, and then Adrian and Eduardo, who's been working in drug targets in different disease conditions. So with that, thank you very much.
So great talk. My question is, how do you